Hello everyone, my name is Mark van der Bogart. I'm a researcher at the Department of Intensive Care Medicine at the Radboud University Medical Center in Nijmegen in the Netherlands. I have nothing to disclose for this presentation, so no conflict of interest. And as you likely may know, delirium or acute confusion occurs in many of our ICU patients. And in our general ICU group of patients, this is around the 30%. But in the group of patients that are mechanically ventilated, this prevalence rate can go up to over 50% with a median duration of around 2 to 3 days. And we know that delirium is associated with worse outcome, a prolonged stay on a mechanical ventilator, more reintubations, and more accidental removal of tubes and catheters, but also a prolonged cognitive impairment. And as said, patients can suffer from delirium for just a couple of hours to some days, but also to persist for a longer time, for even weeks or even months. And this latter is for a small group of patients and is so-called persistent delirium. And delirium duration often considered as a surrogate measure for delirium severity. Several studies already demonstrated worse long-term outcomes of patients with delirium for a longer duration. And however, delirium duration has a very skewed distribution. The persistent delirium group has never been separately studied before, including the risk factors for persistent delirium. And especially since it is such a small percentage of all ICU delirium patients, the persistent delirium group is always underrepresented in those studies. And the attributable role of persistent delirium is therefore unknown. So what is the role of persistent delirium duration with patients' outcome on the short term and on the long term? That was the aim of our study. And for the study, we included adult ICU patients admitted between July 2016 and February 2020 in one of the two hospitals. And patients needed to be accessible for delirium. So patients with persistent coma, unable to speak the Dutch language or to understand the Dutch language, were excluded. And delirium was assessed 3 times daily. And importantly for this study, we had all ICU as well as all hospital delirium assessments for this. So for the entire hospital stay of the patient. And a positive delirium screening on a day was counted as a day with delirium. And all delirium days were subsequently summed and excluding for the non-delirium days and the coma days in between. So to determine the long-term outcomes, we used the questionnaire of the Monitor IC study. And this is a long-term follow-up study with questionnaires containing all domains of the post-intensive care syndrome. So we have patients' health status from before ICU admission, so it's so-called the baseline questionnaire, as well as the 1-year outcomes. And we use only well-validated questionnaires, and most of them are also part of the core outcome set. And all questionnaires are so-called self-reported outcome measures, the PROMs. For physical health, we used the CIF-8 for fatigue measurement, and we had a 30-item list of new physical problems. For the cognitive health status, we used the cognitive failure questionnaire consisting of 40 items. And for mental health states, we have the hospital anxiety and depression scale and the impact event scale revised for the post-traumatic stress disorder. And for patients' health status, we use the clinical frailty scale as well as the quality of life questionnaire, the EQ5D. In total, we had almost 7,000 eligible patients for the study, of which 2400 could be included, of which we have the baseline questionnaire as well as the 1-year outcome questionnaires. So the 2400 patients that were included had a mean age of 63 years. Most patients were were males. 1/3 was acutely admitted to the ICU, and most patients were mechanically ventilated. The prevalence rate was 22%, and most patients had no delirium episode while in the ICU. That was around for 1,850 patients. Almost 500 patients had a non-persistent delirium, so a delirium duration of less than 14 days, and 35 patients suffered from persistent delirium of at least 14 days. And this last group of interest was around 7% of the total group of patients with delirium. And the median duration for the non-persistent delirium group was 2 days, and for the persistent delirium group, the median duration was 20 days. Patients in the persistent delirium group were the oldest patients, were the most severely ill, expressed in their Pacher score. Most of them were urgently admitted. Also, most of them were mechanically ventilated, more often physically restrained, which goes up to 91% in the persistent delirium group. And also due to the number of delirium days, these patients also stayed the longest in the ICU and also had the longest duration hospital admission time. And this was for the persistent delirium group, over 40 days median. Excuse me. So these are the results of patients' pre-ICU health status, and as you can see here, we had 3 groups that did not differ for fatigue, not for depression symptoms, also not for the cognitive health status, and also not for frailty. But in the non-delirium group had the least anxiety symptoms, as you can see at the second place. For each health domain, we calculated the change score by subtracting the baseline score from the 1-year outcome score. And as you can see here, the non-delirium group had significantly the lowest fatigue score compared with the patients with delirium, and also this was the fact for frailty. The delirious patients worsened the most in their level of frailty and was the highest for the persistent delirium group of patients. In the mental health domain, we found that patients that did not experience delirium during their ICU stay, their symptom score was not changed after 1 year for anxiety and depression, and showed a significant increase in symptom score in the persistent delirium group for depression. For post-traumatic stress disorder, we had no change score because we don't have the measurement of the baseline. In the cognitive domain, the persistent delirium group had the highest increase in the cognitive failure questionnaire score, indicating a significantly more cognitive impairment in this group compared with the patient without delirium, but also for patients with a non-persistent delirium. Furthermore, the patients with persistent delirium showed the most decrease in quality of life 1 year after ICU admission. To determine the association of the different delirium groups with the different domains, we first dichotomized the outcome scores using the pre-specified and validated cutoff values. We then aggregated this into a composite score, and an abnormal composite score was defined as at least one or more abnormal separate patient-reported outcome measure. And with this, we were more sensitive to find a difference due to the small number of group of patients in the persistent delirium group. In the performed regression analysis, we adjusted for relevant confounders, and patients with persistent delirium had an almost 4 times higher chance for or odds to be cognitive impaired 1 year after ICU admission. So what can you take or should you take from this study? First, patients with delirium in the ICU group had worse long-term outcomes in all domains. Not only the presence of delirium, but even more the duration of delirium is associated with suffering from cognitive impairment on the long term, and especially persistent delirium. So the longest delirium duration had a significant role in cognitive impairment. And this all emphasizes that we not only need to prevent delirium, but also proper treatment, both non-pharmacological and pharmacological, if needed, to shorten delirium duration. Thank you for your attention.